Professor Stanley Kaye,
Yeah.
thank you very much for giving us precious time at ASCO here in Chicago. It's a very exciting meeting, and you're going to tell me a little bit about it, particularly related to ovarian cancer and how it's going to impact on the Institute of Cancer Research, which you run
Yes.
in London. Tell us about the ovarian cancer stuff.
Well, I think what's going to happen in the next 5 years in ovarian cancer is a question I often get asked, because we're getting involved in targeted treatments in our unit and obviously getting to understand what's happening in targeted treatments. And I think there are probably two big bags that are going to really change the treatment. One is VEGF targeted treatment, the whole avastin story, which is about to take off, and we're going to hear at ASCO in about an hour, actually, the results of the first major, first-line randomized trial that demonstrates that avastin, given as a maintenance treatment, not with chemotherapy, prolongs survival with a hazard ratio of 0.7.
Overall survival?
Yeah.
Wow, that is news.
And I think that the reason that avastin hasn't made it in ovarian cancer before is a kind of commercial thing, not a scientific thing. You know, the data in the other diseases has been a bit equivocal. But what's interesting is that it does not, as I see it, add to chemotherapy. So it's the first time that it's been separated. The effect is a maintenance effect. Yeah. Now, this is going to put the cat amongst the pigeons, because it's going to be very expensive, and there's going to be lots of issues about who should get it and other alternatives. Actually, last year at ASCO, we had this really interesting issue about weekly Taxol. And a weekly Taxol has an anti-angiogenic effect, and that prolonged overall survival too. So that, I think, in terms of the way that targeted treatment is going in ovarian cancer, there's no doubt in my mind that VEGF targeted treatment is going to make a major impact. Probably
after remission induction with standard carboplatin
Yeah. We've been working with actually one of the small molecule anti-angiogenics called cediranib from AstraZeneca. Very good indeed. We've seen lots of single agent activity. Yeah. So I think of the solid tumours, with the exception of renal cancer, VEGF targeted treatment in ovarian cancer is very likely to make an impact. The problem is that there's no way of picking out who's going to benefit at the moment. There's no marker. But the second area that's going to really take off is a PARP inhibitor story, which is basically based on the fact that ovarian cancers, some people say it's a disease of DNA repair deficiency. So if cells are deficient in homologous recombination, one of the methods of DNA repair, endogenous DNA repair, they're exquisitely sensitive to this PARP inhibitor, which 2005, 4 or 5 years ago, in the lab, turned out to be spectacular. We started to work with it, and it's our third or fourth ASCO now that we've presented data on the PARP inhibitor. And we couldn't believe the first data, because tumours shrank with this drug that had no toxicity. Patients said to us, this is nothing like chemotherapy, and we couldn't quite believe it. So in fact, we were delighted that an international trial showed the same thing, roughly 50% response rate in women with resistant, well, either sensitive or resistant ovarian cancer, but recurrent ovarian cancer. Right. Now the big news at this ASCO, because that was done initially in women with genetic, with familial ovarian cancer.
BRCA1 or
exactly,
mutations,
which is
mostly one, of course,
which is a relatively small proportion. But what was kind of known from the lab was that defect in ovarian cancer that's present in this germline BRCA is also present in a much bigger proportion of ovarian cancer in women who were never known to have familial, no family history, no germline BRCA mutation, but had this same defect in the cells. In fact, the calculation was that in the commonest ovarian cancer, which is high-grade serous, up to 50% would respond. So we were really keen to know, was that the case? And yesterday, at the presentation from Vancouver, the same drug that we worked on, olaparib, which is the AstraZeneca drug, was tested in about 50 odd women with high-grade serous ovarian cancer, BRCA negative. And the response rate looked to us to be actually quite close to the response you might have expected from had they been germline. Possibly a bit less. I think that
50%?
No, I think that if you put together the RECIST and the marker response rate, it was about 40%. But the response duration was still what we got, about 7 months.
And this is ovarian cancer resistant or previously treated with a platinum or
previously treated.
Taxane.
I actually asked them the question, what exactly was the breakdown for sensitive and resistant platinum, and they didn't have the answer, but they were all previously treated. So they're all women who hadn't exhausted all conventional treatments, but for sure, this was, for them, I'm sure, a significant step forward.
Do you think the platinum's adding to that DNA damage?
But yeah, it could be. I mean, I think it's selecting, it does, well, actually, one of the questions is whether you should give platinum with a PARP inhibitor.
Yeah.
And the problem there is that when you do that, you get enhanced toxicity. So there is a big momentum to try to develop combination strategies. Hilary Calvert, who actually was one of the godfathers of the PARP inhibitor story in Newcastle, some 8-9 years ago.
Well, we got into that, I remember, because of temozolomide resistance.
Exactly. Well,
and the PARP was one of the pathways
yeah,
that he picked up. Yeah.
But I think that the problem is that when you combine a PARP inhibitor with chemotherapy, you usually have to drop the doses, and that's been a problem with most of them.
But now maybe sequential is the way to go.
Yeah, but I think that the kind of theme that we've got in ovarian cancer that we have in every cancer now is the theme of personalised medicine.
Right.
You know, can we pick the patients who we're going to have to spend the money on, because these drugs are going to be a hell of expensive? And the beauty of the PARP inhibitor story is that there has to be a biomarker, because unless the cancers have got that defect, you wouldn't expect there to be any effect. So this morning, from Boston, was a really neat presentation looking at a gene profile, some genomic profiling of 60 or 70 ovarian cancer samples, matched with another set of patients who are being treated with platinum, to ask the question: is there a BRCA profile? Can you do a test that will say not that these are now germline negative, but that this predicts platinum and PARP inhibitor response? And they've got a profile that looks very promising. So I think we're probably only about a year away from having a biomarker-driven PARP inhibitor program, and there are 6 companies after it. Good. At least, probably more.
Well, we'll see you in ASCO 2011. Thanks very much indeed, Stan.